USMLE style question. A 45-year-old man presents to the clinic with progressively worsening headaches and episodes of blurry vision over the past 2 months. He also reports nausea and intermittent vomiting. His medical history is significant for bacterial meningitis 1 year ago. On physical examination, he is alert and oriented, but fundoscopic examination reveals bilateral optic disc swelling. A CT scan of the head shows ventricular enlargement without a mass lesion. Which of the following is the most likely underlying mechanism of this patient's condition? A. Overproduction of cerebrospinal fluid, CSF. B. Obstruction of CSF flow at the cerebral aqueduct. C. Impaired CSF absorption by arachnoid granulations. D. Increased vascular permeability of the blood-brain barrier. E. Decreased cerebral perfusion pressure due to systemic hypotension. Impaired CSF absorption by arachnoid granulations. Explanation. This patient presents with headache, blurry vision, nausea, vomiting, and papilledema, which are signs of increased intracranial pressure, ICP. His history of bacterial meningitis suggests the development of communicating non-obstructive hydrocephalus due to scarring of the arachnoid granulations, which normally function to absorb CSF into the venous system. Arachnoid granulation dysfunction leads to CSF accumulation, increased ventricular size, and raised ICP. Fundoscopic exam showing papilledema, optic disc swelling, suggests elevated ICP, which can also lead to herniation if severe. Key differentiation from other causes of hydrocephalus. Cause, findings, papilledema. Communicating hydrocephalus, this case, CSF absorption due to arachnoid scarring post-meningitis or subarachnoid hemorrhage. Symmetric ventricular enlargement without mass, non-communicating obstructive hydrocephalus. CSF flow obstruction, e.g. at cerebral aqueduct. Enlarged ventricles proximal to obstruction. Normal pressure hydrocephalus, NPH. CSF absorption without increased ICP. Triad, gait disturbance, urinary incontinence, dementia. Idiopathic intracranial hypertension, pseudotumor cerebri. Impaired CSF, outflow, unknown cause. Young obese women, papilledema, normal ventricles. Why not the other options? A. Overproduction of CSF, rare, seen in choroid plexus papilloma. Would cause hydrocephalus, but is not the usual mechanism post-meningitis. B. Obstruction of CSF flow at the cerebral aqueduct. Causes non-communicating hydrocephalus, leading to asymmetric ventricular dilation. D. Increased vascular permeability, seen in conditions like brain tumors or trauma, leading to vasogenic edema, not hydrocephalus. E. Decreased cerebral perfusion pressure, causes ischemia, not hydrocephalus or papilledema. Takeaway. Post-meningitis arachnoid scarring can impair CSF absorption, leading to communicating hydrocephalus, increased ICP, papilledema, and risk of herniation.